always consider the simplest options first with the patient, and allow the patient to discount those options that they don't want. But from a knowledge base, the patient having a great knowledge of the benefits and risks of each treatment before they make their final decision, I think is really important.
Hello, you're listening to the Dental Protection Podcast, and this is the In Dentistry series where we are looking at diagnostic errors, which are often the drivers for the cases and claims that we deal with for members. In a previous podcast, we considered some of the wider environmental and cognitive issues that can impact decision making. And for this episode, we're looking at the more clinical issues that arise in the cases and claims that we see relating to implant dentistry. My name's Yvonne Shaw. I'm Deputy Dental Director and Dental Underwriting Policy Lead here at Dental Protection. Now, today, both our guests are members of the Board of Dental Protection and bring extensive experience in clinical practice in the field of implant dentistry. I'm delighted to be joined by Dr. Graham Stokes and Dr. Onkhar Dhanyoa. Graham has a long-standing background in implant dentistry, being the lead clinician in a referral practice in Bromsgrove and having a special interest in implants and prosthetics. Alongside his clinical work, Graham has been a vocational training advisor. He's been on the Principal Executive Committee of the BDA and Chair of the BDA Health and Science Committee. He also joined MPS Council as a non-exec director in September 2017. Onkhar likewise has extensive career in dental practice and also in dental education. Since graduating from Newcastle back in 1985, he's been a principal dentist for the Honour Healthcare Group, as well as being clinical teacher at Newcastle Dental Hospital. His clinical interests include dental implants, sedation, and acupuncture. He's also the examiner for the MJDF Royal College of Surgeons exam in England and is a clinical coach for Astrotech dental implants. Separate to this, he's also acted as an advisor for the General Dental Council, been a past president of the BDA Northern Counties branch, and is current chair of the North Tyne LDC. So in this episode, we're focusing on the alleged diagnostic errors we see in cases involving the provision of implants and why some of the errors arise. Now, from a dental legal perspective, looking at the cases we deal with, there are two main areas where these allegations come from. Firstly, in relation to initial assessment prior to treatment being provided. And in the event an error arises in the diagnostic process, this in turn can lead to claims alleging lack of consent and inappropriate treatment. But we also see diagnostic errors arising from a failure to identify a problem that has then arisen with the treatment and taking appropriate action. So perhaps a good starting point for our discussion today is to actually start with the premise that in a lot of the cases we sometimes see allegations that the patient was actually never suitable for implant treatment in the first place. So my first question over to both Graham and Onkhar is, in your experience, how common is it that patients attend to see you that have been referred for implant treatment that actually aren't suitable at all? Perhaps, Onkhar, would you like to pick that up first of all?
Yeah, thank you, Yvonne. Well, patients come from either sort of self-referrals, patients who sort of heard about implants and don't know whether they're suitable or not, so they'll attend and wanting implants. And then there's the other case of patients being referred by other practitioners or their own friends and colleagues. So really, when patients come in like that, you really need to assess the whole patient, obviously to check to see whether, first of all, they're suitable, medically suitable for implant treatment, see whether, they can tolerate the procedures, see whether, again, dentally suitable. So basically you need to go back to the beginning and do a full, thorough examination. And then you plan your treatment from there, really. Would you agree with that, Graham?
I would, Onkhar, and I think the key is back to correct treatment planning sequence and looking at the whole patient and the whole mouth from the start. I would say a lot of patients that come in for implants, a key example for me is the patient that comes in they've lost one anterior tooth, but the rest of the mouth isn't stable enough to take an implant in that one area. So it's looking at the whole mouth. Is there pathology in the rest of the mouth? Is the mouth stable? Obviously, the medical conditions that Onkhar's referred to and alluded to, but it's remembering that implant care is a whole mouth treatment. The whole mouth has to be stable in order to support that implant. And I think often patients that come in where they've had to lose teeth and require a space to be filled, by definition, their mouth needs more work than just that one space treating. So I think that's the key thing, is not to get just concentrating on a space where the patient has a gap, but to look at the whole mouth and make sure all the teeth and all of the anatomy in the mouth is stable, first of all. I also think you've got to look at patients' expectations as well. Patients often seem to think that it's just have an implant and it's there for life. It needs no further maintenance. And I think the long-term maintenance the patients have to commit to before you even embark on that treatment is really, really important. And I'm sure Onkhar's had that as well, Yvonne, where patients don't realize how much long-term maintenance of their mouth and all the other supporting tissues in their mouth, as well as ongoing maintenance of the tooth or the implant itself.
I suppose thinking, is it relatively common that you would then say to a patient, I'm sorry, but I don't think you are suitable? Is that something that you see fairly regularly in your practice, taking into account all those factors?
Yeah, I would say it is fairly common. Or at least you have to say, well, look, there are these other issues within the oral environment. The periodontal disease needs to be made stable. If there's pathology elsewhere, that needs to be treated or taken into account. If there are other edentulous areas other than the one the patient is concerned about, that's, for instance, there's no posterior support to the occlusion and you're thinking of putting a single implant or two implants in an anterior gap for aesthetic reasons without the posterior support, these need to be addressed first, some way or other. And also, I think you need to make sure that that environment is stable for a period of time thereafter before embarking on a further treatment process. Onkhar, would you agree with that?
Yeah, as I say, the first thing would be to ensure that the mouth is healthy. There is no active perio disease, all infections taken care of before you embark on that, and also looking at potential things that can go wrong in the future. So if you have teeth that are going to fail near your implant or anywhere else, which may then complicate the treatment that you're providing, you need to plan for that. You need to plan for, as Graham says, teeth failing further on down the line. How are you going to incorporate the treatment that you're providing now into the future needs for that patient, for the function and for the aesthetics? So it's not just a short-term treatment plan here. You need to really take a long-term view on this and see how that will benefit the patient in the long run.
And I think often, Yvonne, it's worth considering the diagnosis of, even if it's post-event, of why the patient lost a tooth in the first place. Because that can often impact, can't it? If the patient has been a bruxist and has ground on the teeth, and that's for the reason they've lost a tooth, are they going to be grinding on your implant? What's the long-term prevention plans the patient's got to commit to? And I think patient consent is quite important as well. And I know our dental protection colleagues are always very, very keen to ensure that our members get the best consent from their patients they can. But the consent, I think, is also onto the ongoing care and maintenance that the patient will need. I think especially if you've got a multiple implant case, the ongoing maintenance can be quite a commitment by the patient, both to preventative care and any further treatment that might be needed.
I think it ties into the wider piece about what is actually right for this patient. And both of you have had kind of referral practices where patients are being referred specifically for implants. I think one of the things that we see sometimes in the records is that the patient is then only assessed for implants, and there isn't consideration of other treatment options that might equally be or actually be a better option for that patient. And one of the things we talked about in previous podcasts was the risk of tunnel vision or bias, and that risk that actually, because the patient has got the mindset that they're coming for implants and you're providing an implant service, is there a risk that that's the only treatment you look for? And how do you go about avoiding that risk and actually taking that wider view? So have you got any tips or kind of approaches that you take?
Well, again, it's really considering the treatment options, as Graham's already mentioned. I mean, a lot of the patients who come in for implant treatment don't realize that, they can have simpler, less invasive treatments, for example, like an adhesive bridge. They're quite surprised that, that's an alternative, because really what they want is a fixed tooth. And sometimes it's not necessarily an implant that's required. You can have conventional crown and bridge work, or adhesive dentistry, which can actually be just as effective.
Yeah, I would agree with that. And I'd also say a good denture, Onkhar, as well. I think that it's really important to provide every treatment as an option to the patient. Very often you'll have patients coming in wanting a gap at the front of their mouth fixed with an implant, and there are multiple posterior edentulous ridges, and a really good cobalt chrome denture that fits well and works well might actually be better suited to that patient than multiple implant treatments. It might be that they want multiple implant treatments, but if that option wasn't available to them and wasn't offered them, then have you actually got proper consent from the patient for that treatment? So just because you do implants, I think you've still got to make sure you offer a full range of treatment to the patients and properly explain the benefits and risks of each to them before you commence down the treatment. Because if you get a commitment to a treatment in advance without the patients understanding fully the maintenance requirements long term, they might then come to regret that long term, and that comes back to you as the treating dentist. So you've always got to offer all the alternatives, even if the patient comes in and says, the one thing I don't want is, I think you have to explain to the patient the benefits of that treatment, because that might not have been properly explained to them beforehand. And that might not be implant work. It might be, as Onkhar suggested, a resin retained bridge, a fixed bridge, or even a really good cobalt chrome partial denture, for instance. Always consider the simplest options first with the patient, and allow the patient to discount those options that they don't want. But from a knowledge base, the patient having a great knowledge of the benefits and risks of each treatment before they make their final decision, I think is really important. And look at the whole mouth. Always treat the whole mouth, even if the patient comes in concentrating on one area. Look at the whole mouth and make sure it's stable first. I'm sure Onkhar would agree with me on that.
Yeah, I mean that's fundamental consideration, really, Graham. That you can't really do implant treatment without having stable, healthy mouth, really.
And I think that, again, periodontal disease is one of the keys there, isn't it? If there's unstable perio in the mouth, then you shouldn't even be considering implants. You have to get the foundations right first. One of the main reasons implants fail is peri-implantitis. People who have got pockets of more than 5 millimeters and elsewhere in the mouth are more predisposed to peri-implantitis than those that haven't. So we've got to get the pockets below 5 millimeters. We've got to get the gingival tissue healthy first and stabilize the whole mouth before we even consider it. And then, as Onkhar said, consider simple options as well and make sure that's fully explained to the patient with all the risks and benefits.
Essentially going back to basics, isn't it? And it's diagnosing whole mouth before you narrow in on kind of that treatment option.
Yeah, implants are just another treatment, but they have to follow the same basic protocols of proper diagnosis, proper treatment planning, getting the mouth stable.
Yeah, it's the same principles you would apply for advanced crown and bridge work, really. So making sure that if your treatment's only going to be successful if you've got the foundations right, and then the patient can maintain it.
I think talking about the foundations, that beautifully leads me on to the next issue that we tend to see in our cases, which is where implants are provided. We often see allegations when they fail that actually there'd been a failure at the outset to diagnose the quality and the quantity of bone available to ensure that it was optimal. And I suppose there's a risk that if the bone isn't optimal, that the implant might not be put in the correct position, or the implant is going to fail in the long run. So is that something that you often identify in terms of implants you see where they're failing, or what factors would you see that might lead to an error kind of in that assessment of the bone quality or quantity?
I think it's really, once you've decided implants are what the patient wants, given everything we've just said, the next thing to look at is to make sure you're restorative driven. In other words, where do I want the final restoration to be? And that your planning of your implant follows on from that. And then you have to make sure that where you want your implant to be in order to carry the restoration that you're going to place, then it's really important you assess certainly the quantity of the bone and the quality if you can. And it's essential that you do that correctly. Have you got an accurate way of assessing the amount of bone that is available for you? especially when there are other structures nearby, like when you're below the sinus or above the inferior dental nerve. Onkhar, how do you feel about using CT scanning in your implant treatment?
Well, again, I mean, I've been doing implants for about 20 years now, Graham. At first, obviously, CBCT wasn't really available readily in those times, so you had to rely on, normal radiography. But since I've had a CBCT machine, I am absolutely dependent on it. I think it's excellent in dream planning. You can see one-to-one representation of the bone volume. You can actually plan where you want to put your implants. You can see your vital structures, and I really can't work without it. So if you have access to it, I would say a CBCT scan is a great diagnostic tool and helps you in your treatment planning. I mean, as an example, I had an upper canine that I was planning on extracting and placing an implant, and took a normal radiograph, and the bone appeared to be absolutely fantastic. But when I took a CBCT scan, the sinus had come all the way down on the palatal side. So there wouldn't have been any bone if I'd taken that tooth out to put an implant into. So I changed my treatment plan and managed to restore the tooth. And again, that was as a result of being able to see everything and planning accurately.
Yeah, so I completely agree that a CT scan can give you so much more information. But, you need to assess the occlusion that the implant's going to be placed under. Mm-hmm. Is it involved in the guidance? Is there enough space to place an implant? Not just buccolingually or buccopalatally, but also mesiodistally between the teeth either side. So all of those assessments need to be done carefully. But I can't emphasize enough looking at also the occlusion in the rest of the mouth as well. Is the patient a bruxist? Is the guidance involved on the tooth you're going to replace? And really going into detail on those sort of things that make a huge difference. Where is the bone level, vertical bone loss? We often talk about the horizontal bone loss, but the vertical bone loss, what's that going to do to the length of the restored crown of your implant? Where's the gingival margin going to be? Is the patient happy to have a slightly longer clinical crown than the adjacent teeth? That might not be a problem on an upper 5 with a low smile line, but it might be a huge problem on an upper central with a high smile line. So there are all those assessment errors that need to be looked at. But as far as Onkhar referred to with the amount of bone, I think a lot of dentists, we're not necessarily natural surgeons. And for me, I came at implants from a restorative approach and ended up placing implants. But for me, one of the benefits of having a good CT scan is that you've almost done the surgery. You know what you're going to find under the gum before you lift it up. So you know the anatomy you're going to see. You know the shape of the ridge. You know where the deficiency is going to be. You're not working blind. And for me, that's a great comfort. And in my head, I can do the surgery before I've actually got anywhere near the patient. And that takes a lot of the stress out of it for me. As we all know, if you're working in a more controlled, less stressed atmosphere, you tend to make less mistakes. So for me, one of the benefits of the CT scan, just from routine implant work, is that I know what I'm going to face before I get in under the gingival tissue. And Onkhar, I'm sure you have had many experiences like that as well, where the benefit of knowing what you're going to find.
Yeah, I mean, benefit of knowing is great, Graham. Like you say, it takes the stress out. You can plan it really well. You know exactly which implant you're going to use, where you're going to use it. But I also find it very useful in the consent process because I actually go through the CBCT scan and place implants on the scan with the patient there, so I can show them what's going to happen, what the challenges are, So it really helps for the patient to understand exactly what we're doing. So it's a very useful tool.
And I'm sure, Onkhar, that Yvonne and her colleagues are delighted to hear us keep talking about patient consent and actually seeing that implant placed on the CT scan. You're quite right. It makes such a difference because very often the patients say, I haven't got much room there, or I haven't got much bone there. And you can discuss the risks and benefits there.
Well, you were just tying in beautifully to another area that comes up, and it's nerve injuries that can arise in relation to kind of implant placement. And I suppose it ties into what you're talking about, is knowing what the foundations are going to be like, what you're actually going into before you actually start with the surgery. Is there any other kind of factors that you would consider if you do think nerve injury is going to be a risk, and kind of what approaches you might take to try and address that if you've got the diagnosis right?
I think one of the first factors to address, Yvonne, is, does the patient need an implant in that position? We know a reduced dental arch is a perfectly functional state of affairs for a patient to be in, and the patient doesn't necessarily want to just have 5 to 5, for instance. But at least if you've got to tell the patient they've got a reduced dental arch and that is functioning and perfectly acceptable, then they can start weighing up the risks. But yes, I think a CT scan, knowing where the ID nerve is, I think the accepted safe distance or relatively safe distance is to have your implant at least 2 millimeters above the ID nerve. And the benefit of a CT scan is you can, to a certain accuracy, measure that. Always remember, of course, that your osteotomy drills are slightly longer than the implants. So if you drill to 2 millimeters above the nerve, you're actually a bit closer. I like to have a greater margin of error than that. And I like 3 or 4 millimeters above the ID nerve. And I think, Esposito did a Cochrane review recently that showed that certainly over a 3-year period, that shorter dental implants are equally as successful as longer dental implants in a compromised position, such as under the sinus or over the ID nerve, compared to more invasive surgery. So I think that's one of the keys, is first of all, measuring that properly, that you're very carefully identifying where the nerve is and identifying the length of implant you want to place there, and being very careful in how you place the implant. And Onkhar, I know you have a tip on actually preferring the osteotomy that gives you greater vision. I know that because you've told it me in the past, and I use it regularly.
Well, I mean, I prefer sort of slow drilling, Graham, without irrigation. That actually gives me better vision. It can be more accurate, so visibility is improved a lot. Also, I'm sure we discussed this before, also using, sort of infiltrations rather than ID blocks, which can give you an indication if you're getting close to the nerve, you can avoid that. So there's some practical tips, but really the most important thing in my mind is that, you plan it properly, you have your CBCT, and you pick the implant which is going to be at least, if not more than 2 millimeters away. And then obviously good technique to place that. And if using stents helps you to position that more accurately, then that's a good idea to use stents, so you get more accurate placement for your implants.
Certainly, I like that slow drilling technique. And before anyone goes and starts deciding just to drop down a few revs on their motor, Onkhar, we would recommend people go on a course to fully identify what slow drilling really means.
Yeah.
But also, I think there are those other assessments you make during the process of preparing the osteotomy. I think that you can get damage to the ID nerve just from swelling intraosseously post-implant placement. So if you catch a little blood vessel and create a bleed intrabony, then if you've got the osteotomy site pulsing with the blood, then maybe you've got to abort the process and let it heal. So because you don't want to have a bleed blocked by your implant that creates a swelling around the ID nerve area. I think also follow-up is very important. If the patient's numb for a long period of time, then post-implant placement, then maybe you need to take that implant out very, very quickly. And certainly, I believe, I've heard recommended that certainly if by 9 o'clock the next morning, or even if you've placed an implant that morning, by the end of the working day, the patient's still numb, then maybe you need to get that implant out quickly to prevent nerve damage from pressure like that.
Just to kind of wrap up, it's been incredibly interesting listening to you, and so much of what you talk about is about just getting it right in the first place, getting that diagnosis right. Now, a lot of the problems I think with implant dentistry might arise in that initial period, in that short space of time, around the placement itself. But we do see a proportion of cases that actually relate to longer term failures of implants, and it might be several years after the initial treatment that the restorations start to fail, or the actual implant itself fails. So just from your own experience, what are the issues that you tend to see that have led to perhaps implant failure that, they've failed earlier than you would have expected, but they have survived for a period of time? And is there anything in the diagnostic process looking back that you would think, from my own experience, had I done things differently, that might not have happened in the longer term?
Well, again, it goes back to sort of, the initial planning and ensuring that the patient can look after the restorations. But, usually, if the hygiene isn't optimal, patients haven't been looking after it, then that can lead to periimplantitis. You can have, possibly if the restoration is of a poor design where it's difficult to clean underneath and get to be able to clean around the restoration, or if it's a poor fit or there's cement around. So there's many, many reasons, as well as, functional things like, occlusal overload, parafunction, things like that can actually overload the implant and lead to failure as well.
Yeah, very much so. I think, the key two reasons implants fail: long-term periimplantitis. The patient has to consent and commit to an ongoing care of oral hygiene, preventative oral hygiene, both for their implant and for the rest of their teeth. They have to consent to a process of maintaining their general oral hygiene. You might lose a couple of teeth behind your implant that puts too much forces on the implant, which creates overload. I think one of the key things for me is that the occlusion should be checked on the implant on a regular basis. Teeth wear down and teeth give when we bite together, and implants don't. So if you're wearing down the adjacent teeth, you might then get occlusal overload in later years on the implant. So you need to check that the implant is light with shim stock, that it doesn't catch the shim stock in a gentle bite. Then when the patient clenches, it catches that shim stock, and that should be done at every recall, or certainly on an annual basis. And one of the problems, I think, is that patients don't return to have their implants checked. Or if I'm honest, sometimes the general practitioner who's referred the patient might not do that check as well. And it's also important to regularly check the pocketing around the implant and note any changes in there and treat that quickly. And then finally, I would say, I'd love to know Onkhar's view on this, but my view is that prevention of occlusal overload is really important with implants. We know proprioception is much diminished on implants compared to the adjacent teeth around it. So if I've got an implant restored patient, I will always consider giving them some sort of bite guard to wear at night. Whether that be a soft or a hard guard is another discussion. But always think of putting some sort of prevention from occlusal overload during nocturnal grinding for the patient to wear at night. And again, asking the patient to commit to that. Onkhar, I don't know if you follow that sort of protocol as well.
I would totally agree with that, Graham. I mean, I've had a case where, a patient was edentulous, had implants and a bridge fitted, and then started bruxing because they weren't bruxing before they took the dentures out at night. So you only discovered that later. So, prevention is the key, really. So if you're going to provide implant treatment to prevent overloading, I think, providing night guards are an important part of that. And bruxism obviously can do a lot of damage with implants.
And I think it's also fair to say, Yvonne, that implants have a 95% success rate over 10 years, but it's a 75% success rate over 20 years. And full arch implants, about 30% of them are complication free after 10 years. So to expect those issues to arise with implants, issues will arise. Patients, again, need to be informed of that before the start of treatment and treated and cared for in a timely fashion. But I think one of the issues is patients often think they have an implant and they don't have to ever think about that again. It's back to that education at the start of the treatment. This is what having an implant means. It might not last forever. You will need to take care of it. You will need further treatment of it. And you must maintain it and the rest of your mouth at a very high standard. And those sort of things, understanding those from the start of the treatment, both for the clinician and for the patient, often alleviate a lot of the issues that then can follow for our members.
I think one of the things you talked to me about previously was that audit piece and that self-reflection. So when things do fail, actually trying to look back and look at what you would have done differently. And I think that comes with experience, that once you've been in this business for a long time, you can actually see what works, what doesn't work, and learn from that. And I suppose for anybody working or starting out on that journey, this is where the benefit of having mentors and more experienced colleagues to actually support you during that process really comes to fruition, because you can learn from their mistakes as well. And it's been really valuable talking to you both today and just gaining some insights from your experience and kind of all the years you've had of kind of learning from your own implant treatments. So I'd like to thank you both for joining us today and for all your insights. And finally, if you are a member of Dental Protection and want to know more about today's topic, please look in the podcast description for further information. For those of you that are new to podcasts or maybe listening for the first time, make sure you subscribe to the channel to make sure listening is easier in future. You can access this podcast from all major apps, including Apple and Google Podcasts and Spotify. And for more information about Dental Protection, or if you're already a member and would like a certificate for listening today, please look for details in the description. I've been your host, Dr Yvonne Shaw. Thank you again for listening.